I think the biggest problem or challenge that we have to overcome is to bridge the gap between super technical people who are developing these models and then clinicians who are going to be using these models, making sure that everybody's on the same page, understands the limitations as well as capabilities of these models, how it could help them. So these are what I would say the main challenges in those two categories.
You're listening to the Oncology Nursing Podcast, where ONS Voices talk cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
The advertising messages in this episode are brought to you by LUNGevity.
In non-small cell lung cancer, it is critical to test for all actionable biomarkers based on the latest clinical guidelines. Lung cancer patients experience superior outcomes when treated with appropriate therapies, so help them make fully informed decisions before treatment. For more information about comprehensive biomarker testing from LUNGevity Foundation, visit noonemissed.org/HCP.
Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Lenise Taylor, Oncology Clinical Specialist at ONS. Today, we're talking with Nasim Eftekhari, Executive Director of Applied AI and Data Science at the City of Hope National Medical Center in Duarte, California, about how artificial intelligence, also called AI, is being implemented in cancer care and how it affects an oncology nurse's daily work, both directly and indirectly. Thanks for joining us, Nasim.
Of course, happy to be here.
We recently spoke with Max Topaz on the podcast about nurses' role in AI in healthcare, and we're looking forward to talking with you today about its application in oncology nursing care specifically. Let's start with, can you give us a brief overview on how AI is becoming incorporated into cancer care?
So there is a lot of applications of AI in cancer care, so I can't possibly give you an exhaustive list, but the ones that come to my mind, at least the ones that we are actively working on, are early detection and diagnosis, treatment planning, predictive modeling for predicting unwanted outcomes, remote monitoring, radiology applications, pathology applications, improving operations and helping with resource allocation, precision medicine and research. And we also started a year or so in incorporating AI and helping with drug discovery. So those are the ones that come to my mind, but I'm sure there will be others coming up in the rest of the discussion.
Wow, that's a lot. Pretty much the gamut of what you can do in cancer care. And I especially appreciate, and I know we spoke in the previous podcast a little bit about the remote monitoring and how much that's really helping with our patients with not having to travel into centers, and they can have more of their care at home. So I love being able to apply this in a very broad sense with how we're doing these things. Can you tell us a little bit about how City of Hope is using AI in precision medicine and research and business operations and their clinical decision support?
Sure. So at City of Hope, we have a centralized AI department. The name of our department is actually Applied AI and Data Science. And we have 3 teams. Currently, one that is focusing on clinical decision support. We have one team focusing on precision medicine and research, and another team focusing on improving business operations. So the team that is focusing on clinical decision support, as you may imagine, we build AI models for clinical decision support. This team has been in place for the last 7 years, so we have a lot of mature products in this space. Some examples are monitoring patients for the risk of developing surgery complications, sepsis for transplant patients. We predict patient experience. We predict 90-day mortality for our palliative care and supportive care department. These models are all integrated in our workflows. And as we speak, our nurses and doctors are using these models in their day-to-day workflows. These are near real-time models. So, for example, when a new lab value becomes available in Epic, which is our EMR system, in milliseconds, this new data flows into our predictive models. If this new lab value changes anything about the risk of the patient, the risk and the explanations of why the AI model thinks this patient is at risk goes back to in milliseconds, again, near real time. And it's available to clinicians in Epic. So that's what we do in clinical decision support. That is, I would say, our most mature team in terms of we have models already in production since 2020. Then we have our business operations team. We do a lot of efforts in optimizing operations. We do a lot with revenue cycle optimization, things like, accounts predictions and claim denials predictions. We also work on projects to improve like patient throughput and patient flow, decrease wait times, increase the number of patients we can see, because City of Hope is very popular, as you may imagine. And, we would love to be able to help more patients. And last but not least is our precision medicine and research team. Precision medicine has a lot of different definitions. The way we would like to define it is we want to unlock the mysteries of cancer genomics and help patients have better outcomes as well as better quality of life while they're being treated, by considering all of their, treating the whole patient instead of just one mutation. So City of Hope has set out on this journey of precision medicine for a few years now. And we are, through our precision medicine initiative, we are sequencing many, many patients, sometimes even their families. And this creates a very large genomics data set that we can then link in our data lake with clinical data and text data and socioeconomic data. And if there is any variables and sensors data, and we have this 360 view of the patient. This is, the best use case for AI, because it's too complicated of a data set for a human being to be able to analyze. So we try to understand the disease, how a healthy cell becomes cancerous using this data, as well as, what's the best treatment for the patient, answering questions like, why does this, for example, CAR T-cell therapy work on this patient, but not on another patient with the exact same demographics and disease? The answer has to be in their data somewhere, genomics or other data types. So there's a lot we do in precision medicine as well. I know I've been talking for a very long time. We are all over the place with AI. We do a lot. Are there any questions you may have?
My head's spinning because it's just, there's so much. And I think that for me, I've been thinking more about AI as a very novel and newer thing and have been having a hard time grasping it. But you mentioned the whole sepsis and transplant, and we had done that at my former institution probably close to 10 years ago now. And so I was thinking, wow, I was actually using AI that long ago. So I think that a lot of us may not even have gotten to a point where we're understanding how much we might have been using AI for a very long time. And I think the precision medicine piece of it is just fascinating to think about, and being able to look at an individual and their family and their demographics and how that might impact how they are responding to therapy, or how we might be able to tailor their therapy a little bit differently.
Exactly. You're right. We've been using AI for a very, very long time. Recently, we just hear more about AI, but AI is in our lives, in healthcare or not, all day, every day, like, Google Maps, Google search, all of this is enabled by AI, but we may not realize even that we're using it. So yeah, and I wanted to go back for a second to precision medicine and talk about how it's important that we are also looking at family. Let's say someone has a mutation that makes them more susceptible to cancer, and they have cancer now. And as their family member, you're always, under this stress that I may also, develop this cancer. So City of Hope offers genomic testing to the family so they can know if they have the mutation or not. If they have the mutation, they can be screened more often. They may even be able to get some therapy or some medications or preventative measures not to ever develop the cancer. Or if they do, it could be caught early. Or if you don't really have the mutation, then that pressure can be taken off of you and maybe even prevent some unnecessary screenings and treatment.
I like the idea of not only having that increased monitoring, but also taking that worry off of somebody's mind of eventually developing some type of cancer. What are some of the key challenges you've encountered when implementing AI solutions in cancer care, especially when integrating it with the electronic health records and, as we all know, how that impacts workflows?
So challenges are mainly in two categories. There are technical challenges that we have overcome, and there is also non-technical challenges like change management and really changing the workflows that have been sometimes in place for more than 100 years. So for technical challenges, you have to always consider, is this model performing in a decent manner for this application? And that's, depending on the use case, that's different. If you're providing a decision support to someone that is impacting patient care, then you have to be very careful about model performance. So model performance is one technical consideration. Then how do you really technically integrate with the EMR system? It's not easy. EMR systems are not usually very open, and that's a whole challenge in itself to be able to read from an EMR system in real time and feed data back into it in real time. So that's another technical challenge we've had to overcome. Getting access and processing data in real time or near real time has been something we've been working on in order to be able to even bring these models to life. So the technical problems or challenges aside, though, I think the biggest problem or challenge that we have to overcome is to bridge the gap between super technical people who are developing these models and then clinicians who are going to be using these models, making sure that everybody's on the same page, understands the limitations as well as capabilities of these models, how it could help them. How do we make sure that we are helping clinicians, not firing a million alarms or flags in their face every day? And how do we not disrupt their workflows, or how do we not disrupt their workflows, but help them be more efficient? So these are what I would say the main challenges in those two categories.
Definitely something that I think most nurses experience on a regular basis when you're bringing something in. Is this something that's going to add on to my work, or is it something that's going to actually make my life a little bit easier? So I always appreciate when hearing about how people are trying to enhance someone's work and taking that into account when they are adding new types of work that the nurses are needing to do. Building or adopting AI tools can make a really significant impact in cancer care, and it can be super complex. Can you share some insights on how the oncology nurses can successfully approach this work?
For nurses to successfully approach and adopt this work, I think the most important thing is to keep an open mind, to really realize that these technologies can at best take the mundane part of their works away so they can operate at the top of their license. What AI does best is to do things that are repetitive and doesn't require a ton of human intelligence. I think that would be very helpful. Just that mindset could make things more collaborative and cooperative. And that's the only way that we can make these successful. I can never, as an AI scientist, practitioner, engineer, I can never build something for nurses, but I'm sure that we can build a lot of helpful tools together with nurses. So that's what our approach has been at City of Hope, and that has worked very well for us. Additionally, I think what could help is for nurses to learn the basic concepts that are involved in the development and deployment and testing of these models so that they can really understand the limitations and capabilities, as I mentioned before, and they can take an active part in the development as well. So it's not like we build something for you and then we're trying to convince you this is good for your workflows. We try to build together. We try to, as AI and computer scientists, I'm always learning the medical language. I try to educate myself about the clinicians' workflows and language. And I think the same needs to happen on the clinician side for us to be able to, build tools that really work in their workflows for their everyday life.
I want to go back to what you were just talking about with bringing the nurses into the development of something and having the nurse keep an open mind. How do you incorporate nurses in the development of these tools?
We incorporate nurses and clinicians, our end users, for any tool that we develop from the very beginning. So usually the need for something like a predictive model comes from nurses and doctors. They say, we need help with this. And then we start ideation. We start understanding the problem. We meet with them. We try to see what is it that they're trying to do. Is it feasible given the data we have? We go back, we do some research, feasibility study. We come back and say, we think this is something we can predict, with decent performance. Now let's do it. So we usually have bi-weekly meetings. We have work groups for all of the tools that we've developed internally. We have bi-weekly work groups that we get together with our end users, usually nurses and doctors. And for example, we say we have this original version of the model. It has an 80% accuracy. These are the features or predictors or variables we're using to make these predictions. And they look at it and they say, you're looking at these 4 lab values. Yes, they could be predictive of this outcome. But, I think that utilization is also important. I think that these other 2 lab values are also important. Can you look at medications as well? Because medication is also important in predicting this outcome. Then we go back, we incorporate their feedback. We come back and say, yes, your feedback was great. We are now at 90% accuracy. So we do this in the entire development phase. Like I said, we try to explain how exactly these models are working because transparency is also very important. And then once we are at a point that we say, okay, this model is good enough now for a pilot, we work with them to understand where should this tool come in their workflows. Where do you want this score or risk show up in Epic so that it's the least disruptive and it's showing up at the right time and right place and you can actually use it. So we design a pilot. We look at, it's different for different tools, but at least for 3 months, we are in a silent pilot where we just look at how the model is working and if it has the same impact and performance as we were expecting. In this entire journey, we have our bi-weekly meetings. Even after we're like, okay, this model is good, pilot results are good, let's go live. Even after go live, we keep our meetings, maybe not bi-weekly, but maybe monthly or quarterly to get feedback, because that's also very important after go live. How can we improve these models? Do you really like what you're seeing in real life? Is it helping you or is it driving you crazy? We have surveys that we run every 3 to 6 months so that if people are not comfortable to say that, these tools are not good in our face, they can anonymously let us know. And then we analyze the survey results. Based on the survey results and the feedback that we get, we go at most every 3 to 6 months, we retrain these models and try to optimize and improve them. So it's an ongoing process. It's not something that we build, we deliver, and we are done. All of our models, even the ones that have been in production for the longest, we are still doing this. We are still getting feedback. We are still improving, and we are still retraining models, not only with new data that becomes available, but also with the feedback that we get from our users.
That was very helpful. And I love the incorporation of both open feedback as well as anonymous feedback. And I love the comment about retraining the model, because I think it just speaks to how all of this is kind of an iterative process and learning things along the way. That's kind of a segue into my next question. Can you elaborate on some of the methods or key performance indicators that you've used to measure the effectiveness and the value of these technologies in cancer care?
We have qualitative metrics and we have quantitative metrics. The qualitative metrics I talked about a little bit in the last question, for example, the surveys, how do people really like these models and is it helping them or not? So these are questions that we ask. It's very qualitative. We get, answers in a range of, some people say, I really love this tool. Some people say, I disagree, I don't like it as much. So we have those qualitative metrics. There's also being qualitative or quantitative is also about the application. For example, we are now experimenting with generative AI. We are trying to summarize the outside documentation. When a patient is referred to us, sometimes with hundreds and even thousands of pages of documents, they come in and the clinicians have to go through all of this to understand the patient history and what treatment they've got so far and, how they've responded to it and all of that. You can imagine how time consuming that can be. And it's very you can really miss stuff and it's that much documentation you have to go through. So we are experimenting with a tool that reads all of this and summarizes the key events in a longitudinal manner. So we reconstruct the patient journey in like 1 or 2 pages for the clinicians to be able to go through quickly. So now, is this a good summary or not? You can really look at some quantitative metrics like, okay, out of the 20 events, how many did this generative AI tool get right? Like, okay, 19 out of 20, that's great. But then there's also a qualitative aspect to it. We ask our clinicians to read the summaries and let us know how good they think it is. How, if they had done it, would they do it better or not? So that's also that qualitative aspect, which I don't think we should miss out on. And then as far as quantitative metrics, I can talk about this forever because this is very tough, especially in predictive analytics. Like, for example, we predict sepsis for bone marrow transplant patients. There are some statistical metrics we can use for performance. Like, for example, how many times did you get it right? And this is very helpful when you're training the model because you are not really impacting the outcome. When you're training the model, you're looking at historical data and you try to see if you could have predicted this in the past or not. So there is no intervention. You can really compare your predictions to what really happened in the past and see how good your model is. But when the model goes into production in its life, you make a prediction. You say this patient is at high risk of sepsis. And then clinicians intervene and the patient never gets sepsis. So you can't say, was this a good prediction? Did you make the right prediction and they intervened and sepsis didn't happen? Or was this a false positive? Did you make the wrong prediction? The patient would have never got sepsis. That's no way of knowing that. So there are not a lot of really that kind of precision recall or AUC curves or things that we use when we train the models on historical data. A lot of that doesn't even apply. In this case, what we can look at, though, is we go back and look at some metrics that we are hoping to move. Why is it that we even want to predict sepsis for bone marrow transplant patients? Because we want to predict mortality, because we want to predict ICU admissions because of sepsis. So we look at those metrics that are more like downstream metrics, but then we see that those are moving in the right direction, which is very relieving. So like, for example, after go live, we've had less ICU admissions because of sepsis or septic shock. Or after go live, we've had less sepsis mortality, which is very reassuring. So that seems like we're doing the right thing and our model is working. But if you want to put your scientist hat on, you cannot say 100% this is the impact of the model because there is a lot of different work streams that are trying to improve those same metrics. And unless you do a clinical trial or what we call in industry A/B testing, where you control for everything else and it's only the model intervention that is the variable, you cannot say for 100% that this is the impact of the model. That's why we combine our qualitative metrics that seem to be right in the right direction with the qualitative metrics. We ask our nurses and doctors, do you think this model is helping? Do you think this model is preventing septic shock? And like when a doctor tells me, I saw a flag, the patient didn't seem to be having, signs and symptoms, but they ended up really having sepsis and we did intervene at the right time. So that tells me, yes, the model is doing its job. But again, coming up with numbers that you can say for sure, like, for example, we decreased ICU admissions due to sepsis by 20% and say that confidently and scientifically is very hard.
And that's 100% right, because we're all trying to attack these problems from different angles. And sometimes it's hard to wait, especially when there's some external forces that come into play with trying to get this right and wanting to decrease mortality overall.
If you have patients with non-small cell lung cancer, it is critical to test for all actionable biomarkers based on the latest clinical guidelines. Lung cancer patients experience superior outcomes when treated with appropriate therapies, so don't miss the opportunity to help them make fully informed decisions before starting treatment. You can also spread the word about comprehensive biomarker testing to your colleagues and stay up to date with the latest research on treatment options. For more information about comprehensive biomarker testing from LUNGevity Foundation, visit noonemissed.org/HCP.
Going back to your other example of how much the clinicians must love having that ability to potentially consolidate reams of records that are coming into them for patients that are referred to them to really distill it down to the very important points and those touch points that they need to be aware of when they go in and see that patient for the first time. That's a super cool use as well. One of the AI trends we discussed and linked with Maxim last month was generative AI, which you've already touched on a little bit, and large language models. How do you view the promise and potential risks associated with these technologies in cancer care specifically? And can you provide a few examples?
I think the potential is like really limitless. I'm a very big fan of this technology. I think for the first time, something has come up that can really make a big change in healthcare. I could not say this before generative AI. Although AI was helpful, it has always been helpful, but now I think it's the time to see real change. We are still experimenting. It's a very new technology. We are experimenting with in-house development as well as third-party tools that we are testing and evaluating. Again, there's a huge potential in, like I said, reducing manual labor in documentation, note-taking. There are implications in billing and finance, data abstraction for research or whatever other purposes that we need them, virtual tumor boards, predictive modeling, clinical trial matching is one big use case in oncology, and finding similar patients, something that we've been aspiring to for a very long time, seems to be very possible now with these technologies. And then there is a lot more. So I can talk about the potential forever, but there is obviously also a lot of risk involved. I'm sure you've heard about large language models and generative AI hallucinations. So if you ask a medical question and if the answer is not in the training data, or if the AI model doesn't know the answer, it doesn't even know that it doesn't know the answer. So that's the scary part. So it gives you an answer, and because it knows language so well and it knows how to say things in a convincing manner, it says wrong things in a very confident manner. So if I'm not an expert and if the model does hallucinate, I read it, it sounds very decent. So that's one of the biggest risks that is involved. There are ways to get around that and put guardrails around, the answers and make sure that it's grounded in real information. But that's always a consideration. It's got much better, but that's still always a consideration. The other thing is the risks that are involved in any AI tool, like data privacy, transparency, fairness, ethical considerations, responsible use of AI. These are terms that we see thrown out everywhere, but really getting it right, it requires a lot of work, a lot of thought. Those are the things I feel like are the most important in using any AI, any technology, any AI technology, but also generative AI.
AI governance is an essential aspect of deploying AI in cancer care. Thinking about the processes that you guys have in place at City of Hope, can you explain a little bit about the governance structure and other considerations to ensure that the oncology nurses are using AI technologies in both ethical and responsible cancer care?
So AI governance at City of Hope, and I'm pretty sure everywhere else, is a work in progress. What we are envisioning right now is we have formed an AI executive committee. So this committee meets quarterly and reviews every use case of AI, the ones that we are developing internally, but also the ones that are like third-party tools that claim to solve a problem with AI. Through this executive committee, we are hoping to, first of all, come up with what is City of Hope AI strategy and put in like guidelines and policies in place to ensure safe and responsible use of AI and also effective use of AI, obviously. As you might imagine, for any use case, internal or external, we have to review the technical merits. We have to review it from ethical, legal, and all other like cybersecurity standpoint and a lot of other, different aspects. We are also in the process of forming these subcommittees. Like if it's a clinical use case, then it will go to the clinical subcommittee. Every use case goes to ethical, legal, as well as cybersecurity subcommittee. But then we have an operations subcommittee, we have a research subcommittee. The way we are envisioning to tackle this is when a new proposal comes in, which comes in well ahead of the overall committee, we engage different subcommittees to review given the use case. And then when we go to the overall umbrella committee, we go in with recommendations from legal, from ethics, and from any subject matter experts that have reviewed the use case. And we let the committee know that, okay, we think this has technical merits. We think this tool can really solve this problem. We think that under the hood, the AI is safe, it's responsible, and it's not biased. And then the committee decides if this is something that aligns with City of Hope overall strategy and goals, and is this something that we want to invest in, either developing internally or partnering externally. And then that's how it's governed. And then we decide, is this something we want to go ahead with or not? Again, AI governance is something that should always be a work in progress. So I'm not sure if this is perfect, but we have tried to cover all of the bases.
I love all the background work that goes into that decision to say whether we think we should even go forward with this, because I think sometimes from an end user perspective, it feels like people are just trying something new because we want to try and fix a problem, but we're not sure we're fixing the right problem. So the thought that you guys are doing this ahead of time helps the people that are making these decisions make them with full knowledge of what is going to go into it.
Yeah, and the users also weigh in. So if you're considering a tool to improve clinical operations, the people who will be using the tool will have a say in, yes, we think this tool will be helpful. So it's not just looking at the technical and cybersecurity and ethical and legal aspects, but also, is this something that our users will use? Because that's the ultimate goal. If they don't use it, it doesn't matter how good the tool is, it won't work. The users are also a big voice in letting us know, is this something that we want to move forward with or not?
Just a few more questions for you. What do you think are some of the common misconceptions about AI in cancer care?
The biggest misconception maybe in AI in any industry, including cancer care, is a lot of times people think that AI is a commodity you can buy. You can take it off the shelf and it will solve all of your problems. That's definitely not the case. Even if it's the best AI tool that you're acquiring or building, it needs a lot of engineering, a lot of implementation, a lot of education, monitoring. I think I've talked about all of this. Retraining, impact analysis, feedback to really make it work and to keep making it work for the foreseeable future. So this is not something that you can say, okay, let's spend $5 million, buy this tool, this problem goes away, and we will have a return on our investment. It's a work in progress. It's something that needs a village, many different teams, including the users, to actually make it successful.
What's something about this topic that's not often discussed, but you wish people knew more about?
Maybe one thing I want people to know more about is a lot of times people think that the reason AI has not been so revolutionary in cancer care or in healthcare in general so far is because the technology is not perfect. The models are not 100% accurate. Well, first of all, I think they will never be. I think that AI models will never be 100% accurate, as human beings are never 100% accurate. So that's one thing. But set that aside, let's imagine we have the perfect AI model that whatever use case it is trying to do, it does it perfectly every time. I think that still making it successful is not about the technology, but mostly about people and processes and operational support. I can't say this enough, and I think I've said this in almost every question, but I think that this is not being discussed enough, that it's not about the technology. It's really about people and processes and operation.
That is a really good point. And I think that everybody complains about, as people get more involved with technology and as people adopt it, that they think that it means that something's going to be taking over for the person who's using it, as opposed to it being something that's partnering with the person that's using it. And I can see where AI kind of fits into that category, where it's really just going to accentuate the work the nurse is doing or the clinician is doing. And I think that as oncology nurses are more involved with this and see how it can help their work improve, they're going to want to learn even more. provide some examples of what some additional training or education the nurses might reach out for to further understand AI and how it impacts how they do their work in cancer care?
So the good news is nurses, clinicians in general don't have to get too deep into the AI concepts and, be super technical. I think if they learn, and a lot of people already do know statistics to understand the performance metrics. Like, for example, when we say this model has 80% recall at a 50% precision or positive predictive value, I think that nurses have to be comfortable enough with these concepts to immediately translate that in their head to what that means for their patients. Is this good enough for the particular use case, or no, we should have 90% precision or positive predictive values? So that's one thing. That's not even AI. It's like just statistics to understand how well these things work. And then as far as AI, I think learning some basic AI terminology can really help bridge the gap between, the people who are building or selling you this stuff and the people who are the actual users. Like, for example, understand at a very high level concepts like, what does classification mean? What does regression mean? Supervised, unsupervised, semi-supervised learning techniques, and at a very high level, how each of them work. I think this could be done maybe in 1 hour. It may take a while for it to sink in, but I know that a lot of times AI concepts from afar seem very complicated, but when you really see what these technologies are doing, at the core of it is very simple. So I wouldn't be scared. I would just go in and learn some basic concepts. It will help understand these tools and trust them when you should, and know their limitations and not trust them when you shouldn't. I think that would be very helpful.
Those are some very good points. What are some additional resources for patients and providers who would want to learn more?
These days, there's a lot of online courses. I use them a lot myself. I would suggest online courses for, again, high-level education on AI. There are courses that are 1 or 2 hours. They tell you even if you don't have a lot of math and a statistics background, it will tell you in very simple language what all of these things are and how they work. I think that would be very helpful. Also, one of the things I used recently is ChatGPT for learning stuff. I really, really recommend that. So you can have a conversation with ChatGPT. You can ask, what's machine learning? What's AI? And just from there, take the conversation. And you can say, explain in a very simple manner. I'm a nurse and I want to understand this for my day-to-day work. And it's amazing how it works. And then you can keep asking follow-up questions, like what are different methodologies in AI or machine learning? And, as much as you have time, I think you can keep the conversation going. It does understand that you're a nurse trying to learn this stuff, so it will give you examples exactly in your subject matter expertise. So I think that would be also very interesting. I do that all the time for learning things, and I've found it very helpful.
What a great use of it. I hadn't even thought of doing that. I think I'm going to have to try that.
Yes, you should. And I'm not going, this is not an endorsement of ChatGPT. Any publicly available large language model can do that. Could be Google Bard. It could be anything that is available public facing, and you can just interact with it with no coding, just in human language.
Thank you. That was awesome. Nasim, it's been great talking with you. Do you have any final comments or suggestions for us?
No final suggestions. I just want to say that I'm really, really excited for the path ahead. I think that this is the beginning of magical transformation in healthcare. I hope that, I hope this is the case, and I think this is the case. I think we will see a lot of changes enabled by AI, a lot of efficiency, a lot of helping people, helping clinicians, nurses to be more free of mundane tasks and be able to interact with patients, do patient care, which is what they should be doing, rather than, the things that I know a lot of nurses hate. I think we have a very exciting time ahead of us. I hope that's the case. I hope I'm not wrong.
Thank you so much. I hope so too. Just from the things that you've described to us today and things that we've seen in practice, I think that we're really on the cusp of something great and something that's going to be able to allow nurses to get back to what they want to be doing, and that's spending time with their patients. Thank you so much. It's been great talking with you.
Same here. Thank you so much for having me.
If you have patients with non-small cell lung cancer, it is critical to test for all actionable biomarkers based on the latest clinical guidelines. Lung cancer patients experience superior outcomes when treated with appropriate therapies, so don't miss the opportunity to help them make fully informed decisions before starting treatment. You can also spread the word about comprehensive biomarker testing to your colleagues and stay up to date with the latest research on treatment options. For more information about comprehensive biomarker testing from LUNGevity Foundation, visit noonemissed.org/HCP. Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.